next talk will be delivered by Dr. Bhojo Khelani. Dr. Bhojo, Dr. Bhojo किस नाम से entered हैं वो नजर नहीं आ रहे.
Dr. Malik, he's sitting right next to me, so he'll be, using the same name. And if you could share his presentation, please.
इनकी शेयर तो मैं कर दूंगा, मेरे पास है, लेकिन वो तो फिर स्लाइड चेंज करने वाले फिर प्रॉब्लम होगा ना.
आपके पास है सर?
ये आप चूंकि को होस्ट हैं और ये लॉगिन आईडी यूज कर रहे हैं, तो ये
जी
ईमेल पे मौजूद है.
वो निकाल रहे हैं अपनी प्रेजेंटेशन, बिकॉज़ वी वर ऑफ द ओपिनियन दैट यू गाइस वुड बी हैंडलिंग दिस. लेकिन
नहीं, हम हैंडल कर सकते हैं. देखिए, हम हैंडल कर सकते हैं, लेकिन होगा ये कि व्हेनेवर ही वांट्स, मतलब ही विल बी इन लिटिल बिट फर्स्ट.
डॉक्टर मालिक मैं कर लूंगा.
कर लेंगे.
मुझे पता है वो जो को कब अगली स्लाइड चाहिए, मुझे इल्हाम हो जाता है.
चले आ जा इल्हाम के साथ.
आप प्लीज शेयरिंग बंद कर दें, तो चले मैं कर देता हूँ.
डॉक्टर बोजो का इल्हाम तो कम लोगों को पता है, लेकिन चलें, आप तो उनके यारे बाहर रहे हैं. ठीक है,
एक सेकंड. डॉक्टर बोजो नॉर्मल EEG.
नॉर्मल, डॉक्टर भोजो का टॉपिक है नॉर्मल अवेक एंड स्लीप EEG.
ठीक है. So we'll go through briefly normal awake and sleep EEG. Mainly I'll be talking about adult awake and sleep EEG. So this is the EEG from an adult, and this is an awake record. You heard in prior talks that it's usually we do multi-channel EEG. Like here you can see 4 channels, 8, 16, 20. So, and then many labs also put an extra channel for EKG monitoring, which is not showing in this particular record. And on this side, you are seeing the numbers and letter. Those are for the portion of the scalp where electrodes are placed. Generally, so this is a bipolar montage, and it's running from anterior to posterior. So what you see in a routine adult awake record, when patient is lying with eyes closed, you see very low voltage but faster activity that is in the beta range. So most of the routine EEG activity is divided into 4 ranges of frequency: beta, alpha, theta, and delta. So beta is the fastest, that's over 13. Alpha is the next, that is 8 to 13. And then below 4 hertz, that is 4 waves per second, is the delta, and between 4 and 8 is theta. So what you see so as I mentioned, there is a beta activity which is the faster but very low amplitude. Generally, in normal EEG, there is an inverse relationship between the frequency and between the amplitude. So as the frequency goes faster, amplitude becomes lower. And these are the posterior channel where you see a relatively higher amplitude but relatively slower EEG. That is the alpha activity, and that is in the range of 8 to 13. And often it slightly wax and wane and give a sphenoid formation. So there's an anterior to posterior gradient with anterior beta, posterior alpha in all chains. So that is your awake adult record. Next. Now what you see when you when you are analyzing or reporting EEG, so that is the first thing to see the background. So what different parts of the representative portion are showing the activity. And the important is the posterior dominant rhythm that we call alpha rhythm. Now alpha, when we call about alpha rhythm, so it is in adult, it is the activity in alpha range, which is posteriorly located. And then the third characteristic of it is reactivity. So over here, there's an eye opening which resulted in loss of alpha activity. So you call it reactive alpha activity or reactive posterior dominant rhythm. That is a normal phenomena. So if the posterior dominant rhythm is non-reactive, that is abnormal.
डॉक्टर भोजो, एक सॉरी फॉर इंटरप्शन, आप थोड़ा सा पॉइंटर यूज कर लें क्योंकि पार्टिसिपेंट्स भी कह रहे हैं कि वो हाँ
आई एम यूजिंग इट. So this is alpha activity and
नहीं, वो if you're not sharing, then you won't be able to point it. I can use a point. That's the disadvantage of
co-hosting or hosting. Okay, Sajad, please show the reactivity. Good. So you see on the one side, there's a posteriorly high voltage activity from where your red line is starting. And then towards the second half of the trace, that alpha activity has gone. But at the same time, you see some high voltage deflection in the frontal region. And those are showing, those are the eye movement artifact. So this is the reactive posterior dominant rhythm or alpha rhythm. Okay, next. So now there are some variants of alpha, which are normal variants. So the first is temporal alpha. If you go back, Sajad, one more. Okay, now here, yeah, in the fourth, in the first three panels, you see alpha activity posteriorly in occipital regions. But in the fourth, over here, it is dominant over temporal region or maybe similar with the temporal and occipital. So, but in some people, you can see more alpha in this temporal region rather than occipital region. So that is a normal variant. But in many patients, the alpha also is spread from posterior region to temporal region. Next. Next, yeah. Frontal alpha. Frontal alpha, is the name indicate, it is the alpha which is on the frontal region, which is also called paradoxical alpha, because normally we see alpha over posterior head regions. Now, the paradoxical alpha or frontal alpha in normal people is extremely rare. Sajad, how many times you have seen that frontal alpha in normal people?
I haven't seen it. I think it is very rare.
I think two. So that is extremely rare. But more common frontal alpha is abnormal, which we will see in the next slide. And the other two variants, okay, let's finish this. So now here you are seeing alpha.
Got it.
Here we are seeing alpha, which is more diffuse from frontal to posterior region. Now, if you see a diffuse alpha and patient is comatose, you call it alpha coma. So it is just a descriptive term which is showing diffuse alpha in a comatose patient, because normally when we hear the word alpha in relation to EEG, we always think this is a normal. But in this particular case, this is clearly abnormal. Previously, people used to thought that it is a very poor prognosis, but now people have realized actually it's not. it has a variable prognosis. So you can't determine prognosis based on the alpha coma. All you can say, this is abnormal, this is encephalopathic, but you can't determine cause or clear prognosis based on alpha coma pattern. Okay, next. And often this alpha is non-reactive and many a time non-variable. Now here what we are seeing, the activity is more faster. Sajad, can you point out the, yeah. Now here you see a faster activity. This is, you can argue this is beta activity, which is abnormal, but actually it is harmonic alpha, which is double the normal frequency of alpha activity. And if you go to the later half, you can see reactivity with eye opening. Sajjad, yes. So this is a reactive, but this is a faster alpha. In same record, you might see some normal alpha activity. So this is, I'm showing you just single page, which is showing predominantly faster or harmonic alpha. And so this is a normal variant. Next. ये सिर्फ अल्फा की है, वो कुछ नहीं. Okay, next. Okay, this is I mentioned central alpha. So when you see alpha activity in central region, yes. So I am leaving it because this is a kind of overlap. Dr. Drashewar will tell you more about this. Next. Now, so when you're, so this was the awake record. When you go in sleep, you drift to drowsiness. What you see generalized burst of theta activity. In this particular record, in the middle, you see frontal dominant theta. Yep. And before that, you see clearly alpha activity. So this is kind of onset of your sleep. Next. Next. Now, no, go back. So here in the initial half, you are seeing alpha activity, but in later half, again, you are seeing slowing of the posterior dominant background, but still you can appreciate anterior to posterior gradient. So anterior is beta and posterior is theta. So this may kind of changes, like you see alpha followed by loss of alpha, then alpha come back again, and then again loss of alpha. And you use the term waxing and waning of the posterior dominant rhythm or alpha rhythm. So again, a sign of drowsiness or sleep on. Next. Now, as you enter into sleep, again, you see more slowing, loss of alpha, and there's a mixed frequency activities comprising of beta, theta, and delta activity. And you will also see some slow rolling eye movements, which are not, so you see better, yeah. You see better in bipolar montage, and here it is average montage, but still you can see these slow drifting movement, which are like 0.5 to 1.5 hertz or so. Next. Now, as you enter into sleep 2, the slowing persists, EEG gets more clear, muscle activity lost, text don't have to change filters like Sajad showed you earlier, and you see a faster frequency activity in 12 to 16 hertz. You call it sleep spindles, which are more frequent in, which are predominantly in frontocentral regions. So you can see in the second last second of the sleep spindles, second last channel of the tracing. Yeah. So sleep spindle is the hallmark of stage 2 sleep, or N2, which is non-REM stage 2. Next.
सर अली माउस का एरो भी काम
कर रहा है
मुझे अली सजाद के
तो लोगों को तो दिखाई सजाद ये एरो आपको दिखाई दे रहा है
नहीं वो आपकी स्क्रीन पे दिखाई दे रहा है
नहीं मेरे कुछ स्पाइस हैं जो कि कह रहे हैं कि एरो दिखाई दे रहा है दो
दिखाई दे रहा है
कुछ लोगों को दिखाई दे रहा है सीक्रेट एरो है ये हिडन एरो एनीवेज so now in stage 3 the it become more slower. You see high amplitude delta activity intermixed with theta, but delta is more important if the delta is in the range of up to 2 hertz, and it's in the range of 2 hertz and very high amplitude over 70 microvolt, 75 microvolt, and predominantly in frontal region, but spread in diffuse manner. So this is the stage 3. Normally, we don't see stage 3 in our routine EEGs because you record for just 30 minutes or so, but you do see this kind of sleep in prolonged EEG monitoring, video EEG monitoring, and in patient with polysomnographies. Like this is a record from polysomnogram. Next. Okay, again, Sajad, a question from you. How many times you have seen REM sleep in routine EEG?
Almost never again. Maybe you have seen too. I haven't seen.
You haven't seen.
I haven't seen.
Almost never is my answer. I have seen once. Okay. So I've seen once when I was at Duke University. Over there, I saw one routine EEG that revealed REM sleep.
So did he get an MSLT afterwards?
And so, and there was a one PSG which showed REM sleep almost throughout night. Okay. Like 90% of that patient's sleep was REM. So those are extremes which I saw over there in 2 months. Okay, so in REM sleep, as the name indicates, it is the rapid eye movement sleep. And you can see, yeah, you can mark it. So you see rapid eye movement in artifact in the frontal chains. The EEG activity is mixed frequency. So you may see even alpha activity, but usually slower than that person's awake alpha. The other important thing is loss of EMG activity. So you won't see any EMG artifact during REM sleep. So for PSGs, we always apply EMG electrodes, and chin EMG is monitored when you do sleep staging and characterize REM sleep. So other characteristic is loss of EMG. And third thing is called sawtooth waves, which is again a sharpish theta activity. and which you can see over here in second. Yeah. So this is showing REM sleep. So this is how you go through EEG, and I've shown you examples of the adult awake and sleep stages. Next. Okay. Now, this is, I'll go briefly through pediatric EEG. In neonatal and pediatric neonatal EEG, it is important to determine what kind of EEG is, whether it is continuous or discontinuous. In adult EEG has to be continuous, EEG has to be symmetric. So if you see any asymmetry, that is almost always abnormal. If you see any discontinuity, that is abnormal. On the contrary, in neonatal period, you can have a discontinuous EEG in normal neonates. But the symmetry should be preserved even in neonatal EEG with few exceptions. Now, what you are seeing in the first example, there's a continuous waveform, that is continuous EEG. The next is the incontinuous EEG, where you see a burst, and then there's the interburst period, which is showing a flat line. But in EEG records, which I show you soon, it's not always, it's not exactly absolutely flat line. You still see some activity, but the EEG appear to be discontinuous. And you record the duration of the burst and duration of the interburst, which changes according to age of the patient, whether that kid is born premature or full term. Next. सजाद चलें, आपका काम हुआ है
जी.
So now you see there's a burst in upper trace. There's a clear burst which lasts about 1.5 seconds, but even before that you see some low voltage activity. But following that burst, there is a interburst, or there's a flattening, which is like 1 to 3 seconds. This again followed by a burst of activity, which is of relatively lower voltage amplitude. Now, if you see this kind of record in an adult, this is by no means normal. This is always abnormal. But if you see this in a neonate, especially in premature, this is not abnormal, normal. And in lower tracing, again, you see a burst which is lasting for several seconds, followed by suppression, which is lasting for a relatively lesser period, like 3 to 4 seconds, but the burst is lasting for 4 or 5 seconds, or maybe more than that, because we have just one epoch. So in neonate period, if you see this kind of activity, which you call trace alterna. So it's an alternating period of the activity followed by relative suppression, and which you see in neonates quiet sleep, which is equivalent to our in adult non-REM sleep. But if you see a longer burst, like a shorter burst, like 1 2 second burst, but the suppression is lasting, say, for 8 10 seconds, in a full term neonate, that would again be abnormal. That suggests prematurity. Next. So this is some slide is summarizing just briefly the major electrographic form of the neonatal EEG, like monorhythmic occipital delta activity from 24 to 34 weeks. So again, this is showing prematurity. Delta brushes. So delta brushes, I'll show you examples. With delta brushes, the delta activity superimposed by beta activity, and this is shown in again premature period from 24 to 36 weeks, and after 36 weeks it start to disappear. Rhythmic temporal theta, which is again during the same period, but mostly you see this theta activity around 33 to 34 weeks. Anterior dysrhythmia and enque frontalis, which are shopper activity over the frontal region in 34 to 44 weeks. So usually you see in neonatal period of in term infants. Next. So arrows are showing. So the shopper activity over frontal region, this is enque frontalis. Now, if you see such shopper activity in adult, you would call it abnormal or shock wave, especially if you look at the third channel right below the arrow showing enque, marking enque frontalis. Yes. So this such kind of activity is abnormal in adult. You call it epileptiform activity, as we'll go through that in detail in the forthcoming presentations. And then the frontal dysrhythmia, that is showing arrhythmic delta activity over frontal region. That is again normal for this age, and which is term infant. But so this usually, so this disappear after 44, 45 weeks or so. If that persists, then you might call it either prematurity or abnormality. So you see these kind of shock waves in neonates, not only over frontal region, but also over other regions like temporal regions usually. And these are considered to be normal until unless these are persistently seen at single area, or these are very frequent. Like in a normal EEG, you can see 4, 5 shock waves in neonatal, but if you are seeing like 30, 40 times recurring, then this is considered to be abnormal. But again, its significance is not epilepsy in this age. You call it just encephalopathy. Next. Now this is showing delta brushes. The second channel is showing very classical wave, well-formed delta and superimposed low amplitude beta activity. And then again, you see rhythmic temporal theta activity. And as I mentioned, you see usually around 33, 34 weeks. Next. Now in pediatric EEG, as age advances, you start to see anterior to posterior gradient. At the age of 3 months, you start to see that gradient. At age of 3 months, you'll be seeing still delta activity, delta activity of 3 hertz over posterior head region, but beta activity over anterior head region. Over here, you see like 3, 3, 6, 6.5 theta activity. At some region, it may be more than that, even 7.5 hertz. So you start to see 8 hertz around age of 3 years. So if you see like 7 hertz activity, it would be age around 1 year or so, 1.5 year. But clearly normal background. Okay, now what do you see over here? The most prominent activity is, which catches your eye, is a faster activity at different regions, and which is not symmetric. it is seen on both sides, but it is asynchronous. So these are spindle wave. As I mentioned earlier, spindle waves are the hallmark of stage 2 sleep. And in pediatric age group, you'll see spindles which are at beginning are asynchronous. That means you don't see them at same time on both hemisphere, but that is normal. Um, Definitely for age of 1 year, but that can be discounted even up to age of 2 years. But beyond 2 years, such asynchrony is clearly abnormal. And so if you see asynchronous or sleep spindle in the EEG of a person over age of 2 years, you call it abnormal. Next. Again, over here, you are seeing spindles, um, sleep spindles, and vertex. Uh, so the Sajada is marked spindles, and preceding that is the vertex wave, and this combination, if it spreads more diffusely, that is called K complex. So all these activities, the sleep spindles and K complex are the hallmark of the stage 2, while sleep is vertex wave, uh, though they are present during stage 2, but you can see in stage 1 also. And that activity wanes during stage 3. Still, you can see K complexes and spindles in stage 3, but the amount reduced and the slow activity of higher amplitude increased. Next. Okay, now I'll quickly go through provocation techniques. You've heard about hyperventilation initially, and then there's I mentioned the photic stimulation. Now this EEG is between the marks is showing a change in the activity over the posterior head regions, and which is in relation with the photic stimulation with the flash. So this is called photic driving, and usually this is exactly of the same frequency of the photic stimulation of flashes, but it can be harmonic of that or subharmonic of that, like the alpha rhythm. And usually you start to see it appear around the 10 hertz, but you can see even at 5 hertz, and it may last till higher frequencies of 30, 35 hertz or 40 hertz or so. So but this is a normal response. And in this particular epoch, you are seeing a last channel, which I mentioned earlier, the EKG channel. And you can also see EKG artifact in, especially in the first 2 seconds in last two channels. Sajaz, can you mark out the EKG channel and EKG artifacts? Yeah, so yes, and in the first 2 seconds, you can also see even better EKG artifact. Yeah. So next. Now here again, it's the photic stimulation. And now here you are seeing the artifact over frontal region. Frontal region, this artifact is due to the stimulation of the retina, and you call it electro retinogram. And on one side, the eye was covered, and so the ERG artifact disappears. While on the opposite side, it persists throughout the period. Next. Now, Hyperventilation is another activation procedure, which is in an attempt to provoke the epileptiform discharges or seizure activity. So photic stimulation is one and hyperventilation is other, and both are part of the routine EEG until unless these are contraindicated for one reason or other. Like in hyperventilation usually is not performed in elderly patient, in patient with history of cardiovascular disorders, lung disorders, and in pregnant patients and strokes. So otherwise you do it routinely. Now what you see is a response of the hyperventilation, the slowing of the activity, and you, as you see over here, so that slowing is a normal response. So usually you see that slowing more prominently in pediatric EEGs than adult EEGs, but whenever you see it, this is a normal response. You are interested more in epileptiform discharges, but you have to be aware that this is a normal response, so you do not report it as a non-specific abnormality of slowing. Next. Again, here you see the slowing is of a higher amplitude and predominantly over posterior regions. Next. Now, so this is a summary. In awake, posteriorly you see alpha activity, which is 8 to 13 hertz, and you see blink artifacts, and you see muscle artifact, and you have seen these in the examples which you have seen over last three presentations. In drowsy, the EEG gets slower, and you get mixed frequency activity, blinks and muscle activity reduces, and you start to see in stage 1 some vertex waves and slow rolling eye movements, and you also see posterior occipital sleep transients, which are positive waves over occipital head region. In stage 2, the hallmark are spindles and K complexes, and slow wave sleep, slow waves, that is delta activity of higher amplitude, predominantly over frontal region. In any particular epoch, this should be over 20%. So that suggests slow wave sleep. And in REM sleep, again, you see a mixed frequency activity, slower alpha activity, and rapid eye movement, and sawtooth wave, and loss of EMG. So that is a brief of awake and sleep EEG. Thank you.